See, this is the awkward bit at the beginning when we stare at the screen waiting for the room to fill up. Good morning, everybody. We're just going to give it a minute or so just to let any late arrivals sign in before we get going. Okay, that seems to be everybody in. I'm sure anyone else will just let themselves in quietly at the back. Good morning, everybody. I'm delighted to welcome you all here today to the latest of the CO Research Trust's lecture series. We're delighted to have Dr. Ewan Sandilands with us, who's the director of the Edinburgh unit of the National Poisons Information Service. He's a consultant physician and a consultant toxicologist, and he has been the lead researcher on this CO Research Trust funded project for the last 6 years. And I'm pleased to announce that we've recently agreed further funding so that this project can continue. It's a piece of work that we think is really important, and we hope will become business as usual and can be absorbed into the wider work of the National Poisons Information Service. So I think we're pleased to have you all here. I can see we've got people from all over today. So welcome to people from the Netherlands, from Japan, from the US, and the Isle of Wight. Hello, Stephanie. Without further ado, I'll quickly just do some house rules. I'm going to hand over to Ewan in a moment. Ewan's going to give his presentation. If you could put any questions for him in the chat at the bottom, we'll have a Q&A session at the end. And what I'll do is I'll unmute you, bring you onto the call so you can ask your question directly to Ewan. And if you have any other questions regarding the presentation, during the presentation or the lecture itself, then drop them in the comments, and if it's addressed to me, I can reply directly. Anyway, without any further ado, I don't want to waste any other valuable time. I'm going to hand over to you and thank him for joining us this afternoon. Thanks, Ewan. The floor is yours.
Thank you very much, Adrian. I'll just get my slides sorted. Thank you very much. I hope everyone can see that. Okay, it's a pleasure to be here this afternoon. I recognize some of the names in the chat function, and for those of you who are new to me, it's nice to virtually meet you. As Adrian says, I'm Ewan Sandilands. This is a project that we've been doing as part of the Edinburgh Poisons Unit with the CO Research Trust, and my colleagues Jill Jackson and Daniela Gentile are both heavily involved with Daniela really leading on the project here in Edinburgh. So I'm going to take you through a little bit about our background first, for those of you who are not so familiar with the National Poisons Information Service in the UK, just because I felt it would help to give a bit of context about who we are and what we do on a day-to-day basis. Obviously, it's a well-researched audience here, so we don't need to talk very much about carbon monoxide poisoning, but it's more to do with where we fit into carbon monoxide poisoning. And then really the crux of it is a study of the study that Adrian was referring to of our NPS inquiries relating CO poisoning, and then where we want to take this in the future and where we hope to develop it over future years. So poisoning in the UK, and this, if you think more broadly, this is all poisoning. So this is our bread and butter, what we do. Poisoning in the UK is a very common problem, as it is worldwide. The WHO say it's one of the top 10 causes of death worldwide, and certainly it's in the top 10 causes to be admitted to hospital for a medical cause in the UK. So there's more than 160,000 presentations every year to A&Es across the UK, with many more poisoning themselves, obviously, out of hospital. We are slightly unusual in the sense that most clinicians in the UK either do adult medicine or do pediatrics. We do both, so we do poisoning in both children and adults, and obviously poisoning affects all age groups. Poisoning in children tends to be more just inadvertently putting things in their mouths, and obviously as the ages go up, it tends to go more towards intentional self-poisoning. The cause and the sort of reasons why and the poisoning agent differs, as I've said, according to age. And we do all types of poisoning. So our main job is drug poisoning, but we do have some other interesting poisons, chemicals, snake bites, spider bites and things as well, which are probably arguably a bit more interesting, but obviously much rarer. How is our service set up? Well, this is the National Poisons Information Service. It's quite a small service. It's only 4 units in the UK. I'm obviously from Edinburgh, and we have our sister units in Newcastle, Birmingham, and Cardiff. We're commissioned by the UK HSA, previously PHE, and the Department of Health to provide a poison service for clinicians across the UK. We're slightly different in the UK versus other countries worldwide in that we don't take inquiries directly from members of the public. So we only deal directly with health professionals. So our referral pathway is on the right-hand side there. So if you are a member of a public, then you contact your general practitioner or one of the telephone triage services, NHS 111, NHS Direct, NHS 24, and it's them who contact us. Our information is provided via 2 sources. One is an internet database system, which is called Talkspace. That's in the middle of that referral pathway. And Talkspace is, think of it like a Google of poisonings. It provides information on over 17,000 products, and it provides information on the toxicity of the agent, what clinical features you might expect, and how to manage a patient. Talkspace provides most of the answers, and it is the gold standard method of poisons management advice in the UK. But if Talkspace doesn't have the answer or you need more information, then we have a 24-hour telephone advice line. That advice line is manned in the first instance by specialists in poisons information, or SPIs for short. And these SPIs are excellent at toxicology and can provide all the advice you need, but ultimately they are normally scientists rather than clinicians. And so if a doctor phones up looking for specific clinical information or it's a particularly complex case, then we have a team of consultant toxicologists like myself backing up that rota 24 hours a day. So there's 16 toxicologists in the UK, 4 of which are based in Edinburgh. And during daytime hours, we have 1 on call in each of the centres. And so we split the UK really up into 4 and then answer poison calls from across the country. And then out of hours at nights and at the weekend, it goes down to just 1 consultant on for the whole of the UK. And we bring in Southern Ireland there as well. So it can be quite a busy job if you're on call because you're covering such a large geographical area. So this is a screenshot of what Talkspace looks like. As I say, it's just essentially like Google, but for poisons. And then this is our carbon monoxide page. So carbon monoxide obviously is a poison, and we consider it just like that. And it gives you a flavor. Obviously, it's just half the page that I could fit on the screenshot, but it gives you a flavor of the setup. So we have our alert box at the top, which tells NHS 111 or the paramedic or the health doctor in A&E what they need to know in terms of if they're just seeing the patient, whether the patient needs to go to hospital or not, and things like that. Then a little bit about the type of the product. You can see the menu down there on the left-hand side, which goes off the bottom of the page. So the type of the product, any synonyms, the toxicity of the agent, and the clinical features, and then the management. And so it's really set out like a recipe card, leading the doctor through exactly how to manage it. It's designed to be easily accessible and readable by a kind of middle grade doctor who is the standard of doctor you're most likely to see in A&E if you were to arrive there at any time of day. We're a very well used service. This is quite a slightly busy graph, but just to give you an idea of the numbers, that red line in the middle is the steeply rising red line is Talkspace accesses, Talkspace user sessions. And as I say, we've really promoted that as our primary source of information. And we get over 700,000 user sessions per year with over 2 million hits to Talkspace. So someone accesses Talkspace every 30 seconds somewhere in the UK. So we're a pretty busy service. The blue line down the bottom is our telephone calls, and you can see it's pretty static now. It reduced over in the early 2000s, and that was really because we promoted Talkspace as the primary source of information as the internet took off and all the rest of it, and people got apps and things. And so we get about 50,000 calls a year. The green line that comes in halfway through is when we developed the Talkspace app. The reason that's so important is because that's good for paramedics. Because you can use it offline as well as online. So we have all the advice there for paramedics that are attending the scene, and they can get the information there at their hand. And then the final line is our consultant referrals for those complex cases. So we get about almost 2,500 consultant referrals out of the 700,000 Talkspace accesses, which are the more complex cases. So it gives you an idea of how our service runs and how we're set up. So what about carbon monoxide? Well, obviously, preaching to the converted here, just some basic facts about carbon monoxide. Obviously, it's colorless, odorless, and non-irritant, and that's part of its problem in terms of its recognition, and why people can become potentially quite sick without really consciously being aware of it. Common sources, we all know this: house fires, defective heating appliances, vehicle exhaust are the common ones that we think of when we think about carbon monoxide poisoning. From a health perspective, because that's clearly where I come from, why is carbon monoxide so toxic? Well, it ultimately binds to your hemoglobin, which should carry your oxygen to your vital tissues. But if the carbon monoxide binds to it and forms a stable complex called carboxyhemoglobin, then your hemoglobin is essentially unable to deliver oxygen to those vital tissues. And so you run into problems because you essentially have got lack of oxygen to all the important organs that require that oxygen to function properly. And so it makes logical sense that unless you sort that problem, remove the patient from exposure, etc., then the patient's going to run into significant problem without some treatment. Part of the issue with carbon monoxide poisoning from our point of view and from our research point of view is how it's defined, which makes the epidemiological study of it quite tricky. And by the way, I mean it's defined, so it can be acute or it can be chronic, and that's fairly obvious. Now, within the acute, you can obviously get the intentional episodes where people are deliberately trying to self-harm through carbon monoxide poisoning, and the unintentional episodes, which is perhaps more obvious in terms of people just being inadvertently exposed to carbon monoxide. From the chronic episodes, you can also get obviously the unintentional, the faulty boiler kind of scenario, where it's just chronically exposing patients to carbon monoxide. I've put a dotted line to intentional, because I think in theory, I suppose you could get intentional chronic exposure, but I think it'd be vanishingly rare. And certainly in our data set, there are no cases of chronic intentional poisoning. The very nature of intentional poisoning is usually acute. And then within the unintentional episodes, you can get ones that are obviously fire related, when certainly from a health perspective, we think of a lot more toxicity or potential toxicity with that, because we need to think about cyanide toxicity and all that kind of thing, and the smoke-related damage, and non-fire related carbon monoxide poisoning. And it's this group here that our study focused on, the unintentional non-fire related carbon monoxide poisonings. Why is that? Why do we focus on that group? Well, that's the group that poses the serious public health challenge. Patients in this particular group are often unaware that they are at risk from the poisoning, even after they begin to experience symptoms, and they can often get symptoms for quite some time before potentially realizing the damage that's being done. And public health policy is focused on kind of raising awareness of that hidden danger. Obviously, that's what a lot of the advertising and things and the public awareness campaigns are focusing on, raising awareness amongst the general public, but also identifying and eliminating potential sources. And that was really the focus of our study, as I said, with the unintentional non-fire related CO poisoning exposures, to try and get a handle on the numbers of people who are contacting us and the types of exposures that we are dealing with. It's something that, although we'd collected the data through our routine collection of data from all our calls, we'd never actually specifically looked at before. And it seems funny that we hadn't, because we're ideally placed to do so. So I'm pleased to say that Daniela led the group in terms of producing the recent paper, which has been published in the Journal of Public Health. And that was up to 4 years of data. Adrian said at the start, we've worked for 6 years now. So this is just a screenshot of the paper, but the data that I'm subsequently going to present today is 6 years rather than 4 years. So it's the extra couple of years of data added in. So this is a breakdown of where we got all the information from. So over the 6 years, we've had, as I say, not a huge number of calls, arguably, about carbon monoxide over the 6 years, almost 1,500 calls, but over 21,000 accesses to Talkspace about carbon monoxide. The difficulty with Talkspace from a research point of view, it's absolutely wonderful from a health point of view in terms of treating the patients, but from a research point of view, there's no data held on Talkspace. It's not a patient record, it's not a place to record patient data or information. So there's only so much you can get from it. And that makes life more tricky when you're doing a research study such as this. So we got the information from both the calls and from Talkspace, and the Talkspace accesses, we followed them up. So we get the usernames and login, the usernames of the people that are using it, and we get them to fill in online questionnaires, and then we contact them to try and follow up to get information about the exposure. And obviously you can get multiple Talkspace accesses for one exposure because lots of different doctors can access it. So we need to try and wheedle that down to actually how many patients were involved. So in the 6 years, we had over 4,000 or 4,323 cases of unintentional non-fire related CO exposures, which formed the study group. And the headline figures, well, these are the headline figures, just put very simplistically for ease. As I say, over 4,000 patients, the vast majority, 70%, have no or mild symptoms, which is very reassuring, but it kind of fits with what we know, that often carbon monoxide is actually either asymptomatic or very mild. The problem is that there are some deaths and there are some severe cases in there. There was 11 deaths over that 6 year period. And I'll come back to the deaths in a while. Some of you might be thinking, well, that doesn't fit with other data. And I can explain a little bit about that as we go on. There is a trend, or we were expecting to see a trend, certainly in the winter months. I'm about to show you data that doesn't quite fit with that quite so nicely that you would expect. 60% were in homes, domestic homes, and about 30% due to faulty boilers. So those are the kind of the take-home messages. I'm now going to go through all that and just give you a bit more detail to those figures. So in terms of the seasonal variation, this was it's quite a tricky graph to get your head around, but it's basically each block's going through the different years of the study, and then it's going from July to June. So winter's obviously right in the middle. I think arguably looking at it is not quite as dramatic as we would have expected before starting this study. Few things to bear in mind. That particularly in the last year, and I can say this with some certainty, speaking from Edinburgh, we had a very cold spring and start of summer last year, and that might explain why the orange bars, for instance, stay quite high right up until May. And so the weather obviously will affect these sorts of figures in terms of people using their boilers, etc. But also we're quite interested in the effect of COVID. So people are obviously at home a lot more use of heating appliances and things as everybody's working from home, particularly over the last 2 years. And I think it would be interesting, I think, we're going to plan to look at this data a little bit more detail in terms of extracting the last 2 years versus other years, because I think there might be a bit of a degree of difference there in terms of the effect of COVID. In terms of the location, the vast majority, as I say, occur at home. And then we have a variety of locations that they occur in after that, but all fairly low numbers. The kind of well-known ones that always meet the press, like the tent and things, the barbecue and the tent and things, are actually, while the patients are often very sick, they're thankfully very low numbers. The eagle-eye ones amongst you will obviously recognize that we have quite a large group of unknown. And that's a problem both in the location and in the source. And that's a limitation of our study in the sense that we're only as good as the information that we're provided with. And that's why we're trying our hardest to improve our follow-up techniques to try and hone down on that unknown group, which is so important because we feel like we're missing a reasonable chunk of data there, but it's very difficult to often get that information. And I'll explain a little bit more about that when I come back to the limitations of the study. With regards to the source, there's a bigger list of a variety of sources, but obviously the majority is boilers and other gas appliances in the household, with the other more rare things like fire pits and cookers and barbecues, etc., much, much further down the list. Again, highlighting the kind of relatively large unknown quantity down the bottom, second from the bottom there, a third of cases, it wasn't known the source of the location, the source of the exposure, sorry. So from a health perspective, when we're treating patients, fundamentally as clinicians, the diagnosis depends on three main factors. Firstly, confirming the history. Clearly, if a patient comes in and there's no history of exposure at all, and we're thinking of something else. Identifying symptoms that are consistent with that exposure, and often that's quite tricky because the patient doesn't often recognize those symptoms, and indeed the doctors often don't recognize those symptoms. You have to remember that the average A&E doctor will see carbon monoxide actually very, very rarely. Each individual A&E doctor that works in the UK, when we treat it, because we're looking across the whole UK, we have quite a biased view. We think it happens all the time, but actually each individual A&E doctor will see it relatively infrequently. And then finally, from a clinical point of view, demonstrating an elevated carboxyhemoglobin concentration, which is the gold standard method of demonstrating that the patient has indeed been exposed to carbon monoxide. So in terms of symptoms from our study, we have a huge number of symptoms identified across the patient group. I think it's important, that's important in itself to recognize the fact that carbon monoxide causes a huge number of symptoms, and many of them, as you read down that list, are quite vague. Some of them are obvious and very specific, but often they're from what we would say in the medical world, they're kind of vague, non-specific symptoms. It's quite difficult to pin down exactly what's going on, and there's a whole range of other conditions which could cause symptoms identical to those that are listed there. It's important to note that 30% of patients have no symptoms whatsoever, but the vast majority, the biggest kind of symptom load is with the central nervous system, and headache is the most common. But as everybody on this call will know, headache can be caused by a whole number of things. So it's very difficult often to pin that down. Within toxicology, and this is not specific to carbon monoxide at all, this is in relation to toxicology more generally, we have a method called the poisoning severity score of assigning a degree of severity to each poisoning episode, and the score depends on how it's a subjective score that's applied by the poisons information scientist who's answering the call and discussing it with the clinician. And it goes from PSS 0 to PSS 4, with obviously 4 being fatal and 0 being no symptoms at all. And I guess it doesn't surprise you to see that the vast majority of them are labeled as none or minor in terms of severity, and that fits with what we think, that most patients are not that unwell, and the small minority have severe symptoms, and indeed, thankfully, very few people actually die. But the vast majority have minor symptoms only, which fits with the toxicity. I said a couple of slides ago that we always like to get the carboxyhemoglobin concentration and to assess that along with the patient's symptoms. And so we looked at in our study group to try to correlate that with the poisoning severity score, bearing in mind that the poisoning severity score is a subjective measure applied by the toxicology scientist answering the call. The carboxyhemoglobin concentration is an objective measure that you take from the blood. But you can see that there is a correlation. Unfortunately, we don't quite have the data to show statistical significance, but I think certainly with the eye of faith, you can see that there is a correlation that as you get more severe cases, the carboxyhemoglobin level goes up. That's maybe not surprising. You maybe think, well, that's not rocket science. What's the point? I think from a clinical point of view, where we're going with that is that it would be wonderful to try and get some degree of a prognostic marker in terms of using that biomarker to say, okay, if you have a patient with carbon monoxide poisoning, if their carboxyhemoglobin level is less than X, we can safely send them home. Or if it's more than Y, we need to absolutely admit them because they may run into problems. That's the ultimate holy grail of what we're going for, to try and use that carboxyhemoglobin concentration in that way. A little bit about the fatalities. So as I said, there was 11 fatalities over that study period. Unfortunately, 6 occurred in a domestic setting, 1 in a commercial premises, and 4 we don't know. 10 of them occurred out of hospital, and it's slightly more unusual for us to get called about that kind of thing. That would be more like, for example, a paramedic calling us. And these patients didn't actually ever get confirming blood results in terms of carboxyhemoglobin concentration because they died out of hospital. So the blood tests were never done. But they did present with other patients who had carboxyhemoglobin concentrations. And so the cause of death went down as carbon monoxide poisoning because it was assumed, therefore, that they were in the same vicinity as those who had definitively raised carboxyhemoglobin concentrations. And that just emphasizes some of the difficulties we have with doing a study like this. It's always quite difficult to get hold of the information, and the information in a timely way and time-sensitive way. There was 1 cardiac arrest shortly after admission who came into hospital and did have all the appropriate confirming bloods, but unfortunately had a cardiac arrest soon after admission. A little bit about carbon monoxide detectors, whether we looked at them or not. Actually, we didn't specifically ask in our study protocol at the start whether a carbon monoxide detector was involved or not. Remember, we're dealing with hospital clinicians once the patient gets to hospital, not someone at the source. And so often that information either isn't known by the doctor, but certainly we didn't, with the benefit in hindsight, it would have been more sensible to ask at the start, but we didn't ask. It was often volunteered, however, and so we started to collect the data where it was volunteered, and certainly laterally we started to actively ask for it. And in those cases where we do have it, certainly the vast majority, 85% of the patients have no or minor symptoms, suggesting that the carbon monoxide monitor did do some degree of early warning and had a beneficial effect in getting patients out. 1 slide only, I suppose, about just a little brief mention about that study group, which is not in the paper, but we're going to look at separately, of the intentional self-harm exposures to carbon monoxide. Obviously a different population, a different study group, many more vehicle exhaust fumes, etc. in this group. Majority were male. There's a much higher degree of moderate and severe toxicity. Much fewer were asymptomatic or no symptoms, and 9 deaths in that group. So 9 out of 225 versus 11 out of over 4,000. So a much greater degree of toxicity. And you know, one would expect that from the nature of the poisoning itself. So the conclusions of our study were that I think that we are actually uniquely placed, and I'm going to talk about this in a bit more detail in the next few slides, within the NHS, certainly for national data collection. There's not that many organisations from an NHS point of view that can collect UK-wide data, given that health is obviously devolved. Carbon monoxide exposures obviously are a significant health concern, and that's represented in our figures. You know, we've presented data on over 4,000 patients, and we've had more than 20,000 inquiries to our service over the 6-year period. There is a positive correlation. We feel we have demonstrated that between carboxyhemoglobin concentration and severity. Fortunately, death, severe poisonings are rare, but minor symptoms are very, very common, particularly neurological symptoms. And we don't really know the long-term effects of those symptoms. And carbon monoxide meters, which I've alluded to, obviously have a clear role in poison prevention. Now, I'm sure you're screaming down that there's loads of limitations, and I do accept there are some limitations with this study. You know, we only included exposures where the clinicians contact us. We don't go out looking for these exposures, so we're relying on people contacting us. And you may be surprised to hear that in some aspects of medicine and some A&E departments, while they consider self-poisoning with all sorts of drugs to be an obvious toxicological problem, they actually maybe don't consider carbon monoxide to be a toxicological problem. So they may think they can manage carbon monoxide poisoning and don't ever call us, because they think, well, we'll just give the patient oxygen. We don't need to phone poisons to find out what to do. So we do know that we missed some, because actually carbon monoxide within the health profession, carbon monoxide is often not considered a poison. We're only as good as the data that's provided to us, and we have to remember that patient care is prioritized all the time. So when the doctors phone us, they want to know what to do with the patient. They want to know how to manage the patient in the quickest possible time, in the safest possible method. they're not so interested about providing data for a research study. So we have to take that into consideration and provide the data as best we can in a timely fashion, and try and get the data for research as we go and use and follow up after the event. The interpretation of the carboxyhemoglobin levels is very challenging. It's affected by a huge number of different aspects. There's many patient-related factors. So it can be affected by whether the patient's a smoker or a non-smoker, by any comorbidities they have, any heart disease or lung disease that's coexisting at the time. And you may know or not know what those comorbidities are. You may not know that the patient has any comorbidities or any lung disease, making it very difficult to interpret that carboxyhemoglobin concentration. There's environmental factors as well, which will influence that. So if someone's been exposed to carbon monoxide in their home, it depends obviously on the concentration of carbon monoxide at the scene, the length of time they've been exposed to, and any supplemental oxygen that they've received in the ambulance on the way to hospital before the hospital doctor takes the blood test to measure the carboxyhemoglobin level. So it's very difficult, therefore, to assign absolute importance to that one snapshot of a carboxyhemoglobin concentration and say definitively yes or no, that patient will run into problems, because any one of those patient-related factors or environmental factors may have affected that carboxyhemoglobin concentration. And finally, the biggie in the room, I suppose the big elephant in the room, is that we have no data so far on the long-term health effects. We have lots of data on the acute effects, and we know we can follow up in terms of length of stay of patients and all that kind of thing, but we don't know in terms of the long-term effects. If someone has quite a significant carbon monoxide exposure, what will that do in the long term to their health in 1 year, 5 years, 10 years down the line? So where do we want to go now with this study? Well, there's an element of keeping it going to build up, undoubtedly an element of keeping it going to build up numbers, to obviously to gain power, statistical power, so we can look at things in further detail. But there's certain areas we want to focus on. I've listed them here, but I'm just going to go through them very briefly, just for interest, to see where we're hoping to go in the years to come. We're quite keen to look at the geography of CO poisoning. So because the way that Talkspace is set up, we can map the IP addresses of the Talkspace accesses, which means we can localize exactly where the people are looking up specific entries in Talkspace. So we can use that to, I suppose, draw up a map of hotspots of carbon monoxide poisoning exposures, and then potentially use that to direct public health messages in those areas if we find that there's a spate of carbon monoxide poisoning in one particular area of the UK. So that's quite useful from that perspective. Carbon monoxide detectors, I've kind of suggested that we were a bit behind the curve with that initially in terms of collecting data on it, and so we're kind of tightening that up as we go forward to gain more data on the impact of carbon monoxide meters and their involvement in each of the exposures. And obviously there's changes to the fire safety laws, particularly coming in Scotland actually next week, week after next week. And so there's certainly a lot more awareness in the public domain about things like this at the minute. Low-level exposures is a big area that we feel is a relatively less well understood area, and I've alluded to that a couple of times through the talk. I mean, I think in our study group, hospital patients are overrepresented in our study group. It's predominantly, out of those 4,000 patients, it's predominantly hospital doctors that we spoke to that the inquiries came from. But actually, if you look at NPIS inquiries overall, the majority of our NPIS inquiries for all poisonings come from NHS telephone triage systems like NHS 111, NHS 24, NHS Direct. And so we want to target this relatively unstudied group with regards to carbon monoxide going forward, and try and get more data on these low-level exposures that may actually never get to hospital. And ultimately, why are we doing this? We're all doing this. I mean, we're all probably, the one thing we all have in common is we're trying to raise awareness about this problem. I think we could probably all agree on that. And I think within the health sector, we're probably well placed to raise awareness. Obviously, we've been working with the CO Research Trust, but the Talkspace is such a well-utilised facility. These are obviously the numbers going back to the first slide, but such a well-utilised facility within the NHS, and unique because it covers all health boards. So England, Scotland, Northern Ireland, and Wales. and not only covers all jurisdictions of the UK, but actually within the health sector, it's unique because it covers primary care, secondary care, and tertiary care. So we deal with GPs, and we deal with tertiary referral centres. So there's not many other, certainly organisations within the NHS that cover all jurisdictions and go right through. So we cover horizontally and vertically. So I think we're well suited to raise awareness for this problem. How we're going to do it, how we intend to do it, how we have been doing it. Education is obviously up there first and foremost. We run lots of e-learning and online educational facilities. So our e-learning, Tox Learning website is well used by doctors, paramedics, nurses, etc. And that's free for them to use. And certainly we're developing new modules about carbon monoxide poisoning and all the rest of it all the time. We haven't got fancy slides for these, but Tox Talks and Tox Updates are CPD events that we run in-house ourselves. And obviously with the advent of virtual learning like we are today, it's much easier to get a big audience across the UK. And then finally, spreading the knowledge, obviously, things like this, obviously, but through peer reviews, publications, presentations at conferences, and interaction with the Royal Colleges, which we're doing all the time, and the universities in terms of spreading that knowledge and teaching is one area where we're trying to really get the message out there of the dangers of carbon monoxide and the treatment options that are available for people. And finally, a little bit about more I suppose the future, a bit more beyond that, beyond the immediate future. We're looking at setting up a feasibility pilot study using data linkage in Scotland. So Scotland's well set up for this because within Scotland, every patient has an identifiable NHS number that stays with you for your entire life. And so you can track patients anonymously and see their interactions with healthcare, all aspects of healthcare settings, both primary care and secondary care. And we're working with the FAR Institute to try and set up a data linkage project where we link health data with data from gas networks. And so that we could anonymously link that data and therefore, essentially in simplistic terms, follow patients who have been exposed at home where the gas network has been out to identify a potential carbon monoxide exposure, and whether the patient goes to hospital or not, we can then follow that patient through their lifetime and see any future contacts with health services and potentially try and do big data study to look at the potential long-term impact of carbon monoxide poisoning on their long-term health. So that's the goal, the kind of holy grail, what we're aiming towards at the end of the day. But obviously there's a bit of work to get there, not least all the ethical dilemmas of the data permissions, etc., to get all this set up, which, as you can imagine, are fairly significant. But in the meantime, we're going to keep going with the study that we've done so far with those additional aspects that I've explained. And with that, I think I'll just stop. I hope that was informative and helpful. A few acknowledgements, obviously Dan and Jill mainly. Jill's unfortunately not able to join today, but Dan's on the call with me. All the staff from the NPS and obviously the CO Research Trust, in particular, Adrian, who's been very supportive throughout. Thank you very much indeed.